Good afternoon. If we could just get Professor Lees to stop sitting on a table and take a seat, that'd be excellent. Welcome to Grand Rounds. My name's Tom Forden and I'm a chair of Grand Rounds. This week we've got a talk about diabetes, very deliberately started off and hosted by someone who's not a diabetologist. This is apparently a very important part of the process, but I've known Pavan for a number of years and he's heavily involved in improvement of patient care, and he has a role to try to improve the lot of your diabetic patient whilst an inpatient. And he's going to just give us a few introductory slides about what he's done and how he went about it, and then we've got two presentations which I'll leave Pavan to introduce. So I'm looking forward to learning about this new thing of diabetes.
Thanks, Tom. Good afternoon, everyone. As Tom said, my name is Pavan Ragu, one of the anaesthetic consultants in Tayside. And as Tom said, I'm not a diabetologist, so if you want to know anything about diabetes, don't ask me. It's basically based on one of the Scottish Government initiatives to reduce the unscheduled bed days in the hospital. They've initiated this program called Improving Inpatient Care for Patients with Diabetes. So Tom very kindly has given us a mnemonic, which is quite hard to remember, RUBDIICPD. So it's basically reducing unscheduled bed days and improving inpatient care for patients with diabetes. I had to say it a few times before coming here just to make sure I get that right. Okay. Very quickly tell you what's the problem. 1 in 20 in the population is diagnosed with diabetes. So that's a massive number. And not so surprisingly, 1 in 5 hospital inpatients have diabetes. So that itself shows the impact diabetes has on NHS resources. We always talk, being an anaesthetist, acute care is probably the most important thing. And we all talk about ABCDE approach and all. We do a lot of training. We all work around cardiac arrest, how to deal with it, and that kind of stuff. But these chronic conditions, they kind of get ignored a little bit, and they don't get their due importance. So hopefully with all these things, people will understand the importance of this and start working towards the improvement. And it's not surprising, insulin is one of the top 3 medications that comes with the in the error section as well, because it's not well understood. So what we are trying to do, as I already said, the Scottish Government is trying to reduce the bed days by 400,000 by 2018. This is in whole of Scotland. So I've taken the lead role as a non-diabetes specialist, because one of the things we just did a questionnaire. Some of you may remember the 2 medical students were walking with their clipboard asking a few questions about diabetes management around the hospital, and the most common answers we got was, if there's a diabetic patient, let's just call the diabetic team to manage the situation. We shouldn't be doing that straight away. So that hopefully, with all the things that are going to happen in the next few months, that'll become obvious. So my role is to implement the inpatient diabetes care programs, mainly in all the acute areas in the whole of Tayside. One of the key things that's come up with that questionnaire is education. So a lot of people are unaware of the resources that are available and what they should do when they encounter with a diabetes patient. So we have plans of different ways of increasing the education, including going to the wards and targeting the nurses and the junior doctors, because it's quite difficult in the current scenario for them to take off and come and attend a big lecture. Also, there are a lot of resources available. We'll be advertising about that soon. There's e-learning in the form of LearnPro modules that are available as well. So, without taking too much time, I'm going to introduce the first speaker, Debbie Voigt. Most of you know. She's from NHS Tayside. She's a diabetic specialist nurse, and also she's got a specific role in the Scottish government initiative. So I'll let her say about that, and she's going to tell us about getting the basics right. So just put the presentation up. Thanks, Debbie.
Thank you very much, and apologies from Dr. Stuart Ritchie, who's the consultant physician from Edinburgh who works with the Scottish Government along with me to try and implement Diabetes Think Check Act. It's not Diabetes Think Check Act is a national programme to improve inpatient diabetes care for people who've been admitted to hospital with their diabetes as opposed to because of their diabetes. So we're trying to embed good inpatient diabetes care. So in the background, diabetes accounts for about 12% of inpatients' costs, so we're a very expensive long-term condition. But 1 in 5 people in hospital have diabetes, and up to 40% of these people will be treated with insulin during admission, whether it's IV insulin for a surgical procedure or whether they start on insulin because they're ill. Nationally, only a minority of inpatients have input from the specialist diabetes team, and I think here in Nine Wells, because we've redesigned our services, we have a good inpatient team. We've got the Scottish Diabetes Improvement Plan, which asked us to improve the experience for people admitted to hospital who have diabetes. It was felt that the people often had a bad experience in hospital. Their insulin was taken away from them, they didn't get their meals on time, their blood glucose levels weren't checked often enough. And again, I think we're quite lucky in Tayside, we don't get an awful lot of poor feedback. And then we've got the help of realistic medicine, where we're asked to identify and manage clinical risk, and there's plenty of risk associated with diabetes, whether it's the diabetes itself that causes the risk, people are more at risk of foot problems in hospital, or whether it's the medications we use for diabetes and the risk of hypoglycemia in particular. As Pavan alluded to, we got the letter from the government on the 1st of March, and that was very powerful because we've now got non-specialists in each organisation heading up inpatient diabetes care. The letter came out in March, and come December we have to feed back to the Scottish Government to see how well we're doing. So it's looking at electronic links for people with diabetes, looking at implementation of hypoboxes and managing hypoglycemia, and getting ward champions on the ward floors to help embed inpatient diabetes care. So if we look at the people who have diabetes, they come from all walks of life. Diabetes knows no social bounds. In an NHS Tayside, we probably have around 300 people in hospital every day with diabetes. And we know that because we've got good electronic links, which I'll demonstrate. We know that when we look, about 40% of these people are 80 years or older, so we have an elderly population, and we know that around 40% are treated with insulin. Nationally, in England and Wales, we do the NADIA audit, so it's National Diabetes Inpatient Audit, and these data have proved very, very powerful down south of the border to get inpatient diabetes services. They face the same challenges as any other hospital. There's medication errors, there's people developing ketoacidosis. They didn't have the same resources, inpatient nurses, but that's improving all the time, and it's on account of the data. Unfortunately, they didn't do a national audit in 2017, but there's a plan to do it in 2018. We don't do a Scottish audit, but we could do our own little NADIA here if we had the resource to analyse the data. So what is Diabetes Think Check Act? You can see the logo down in the corner here. That's our brand there, which has been quite a powerful brand for us, because before we used to speak about diabetes in Scottish hospitals, and it was called the DISH programme, and that didn't really resonate very well. So we put out to lots of healthcare professionals and patients and asked what would be a good logo, and we came up with this. So it's an initiative to improve the quality of care offered to people with diabetes, embed good practice in the ward, and designed to upskill the non-specialists, because the diabetes specialist team cannot see every patient who comes into hospital. So what we need is the ward nurses, ward doctors, dietitians, anybody who works with patients in the ward to be aware of the basics. So our key focus for improvement is recognising people who have diabetes when they come into hospital. And again, we've got good processes here in NHS Tayside. The majority of people who come into hospital acutely have a blood glucose level done. So that picks up some people not previously known to have diabetes, and it picks up the people who have diabetes and sees what their glycemic control is. We want good blood glucose monitoring, prevention and appropriate management of hypoglycemia, and safe management of insulin. So why is it important to recognise people and refer them to the diabetes team? So we need good monitoring to identify any problems that's caused by illness. The stress response to illness is to put the blood glucose levels up. People take medications for their diabetes that put their blood glucose levels down. So we need to recognise people who have diabetes so we make sure that they are monitored appropriately. And the other thing is medications are administered in timing with meal times, so the ward staff, healthcare assistants need to know, does this person have diabetes, need to have their medicine and their meal together. And also people with diabetes are at risk of foot problems, so anybody who has diabetes should have their feet checked on admission to hospital. Blood glucose monitoring identifies the efficacy of diabetes management. There's nothing rocket science about this presentation, it's just embedding good practice. We have steroid-induced hyperglycemia, and we had a case this week, somebody not previously known to have diabetes has come in diabetic ketoacidosis following steroid use for another condition. We had another lady admitted to AMU, just had a 3-week treatment with steroid. Her diabetes has gone completely off and she's required treatment with insulin. So steroids are widely used across the hospital and in GP practice, and we need to know to check blood glucose levels in people who have diabetes and also those who don't. And we have the connected blood glucose levels here, and the data from these are very powerful. We have electronic linkage for our blood glucose systems. They're linked to Sky Diabetes, Track Care, and the Roche connected blood glucose data. So when I come into work in the morning, I can put my computer on and I can see a table like this, and this is all dummy data, so it looks a bit daft, some of it, but it gives me the date of birth and CHI of a person, their name, their age, their type of diabetes, when they were admitted, where they were admitted, how long they've been in hospital, and I can get some of their clinical markers like their HbA1c, renal function, whether their feet are at risk, whether they've had their eyes screened, and now we have the ward blood glucose levels. So that's been a tremendous addition to our care. We can look at patients virtually. If they move from the stroke ward in Ninewells to Stracathro, we can follow patients on virtually. We can go and proactively target people with diabetes in the ward. But this screen is only seen by the specialist team, and that's not what Diabetes Think Check Act is all about. It's about upskilling the generalists, and we want to find a way to share these data. If we look at the glycemic control, this is the sort of things we'd like to share with the ward staff, so we'd like them to be able to see this on their ward computers. This is the blood glucose control of a lady in her 60s. She's type 1 diabetes for a long time. On paper, it looks as though her blood glucose levels are fine, her HbA1c is good, treated with twice daily insulin. You can see during 3 admissions to hospital, she's had absolute chaos in her blood glucose control. She was admitted to cardiology, so hypoglycemia was particularly problematic for her. She had poor renal function, and this is somebody who's had input from the diabetes team during admission, so you can see that some patients, even though they have generalist input and specialist input, they still have problems with their glycemic control. And quite often we'll hear people with diabetes saying, I don't want to come into hospital, I don't want to hand over my blood sugar control to somebody else, I don't want my insulin taken away from me because I know my diabetes best. So if we look at prevention and appropriate management of hypoglycemia, we've got hypoboxes in every ward in NHS Tayside, we think. We frequently do audits to see whether the hypobox is there, whether people know that the hypoboxes are there and that they're stocked with appropriate sugary treatments. There's treatment algorithms in each box. And this is a study done in Edinburgh looking at nearly 4,000 episodes of hypoglycemia during a period of 1 year, and it's looking to see when are people hypoglycemic in the wards. And what you can see is there's a problem first thing in the morning. Now sometimes that is because people are fed at 4 o'clock in the afternoon with their tea, and then they get no supper before they go to bed at night. It's also a time in the morning when the ward's probably particularly busy with people waking up, having medicine rounds, having their breakfast. So with this knowledge, we need to check blood glucose levels on a regular basis during hospital admission and acute illness. If we look at our electronic systems with diabetes, we can now feed this information back to all wards, and this is the inpatient blood glucose audit for hypoglycemia. So if you see at the top, you've got the hospital, you've got June, July, August, September, and that's looking at the total number of blood glucose levels that have been done in a month, the number of episodes of low blood glucose levels, and the time to resolve a blood glucose level. And we've been looking at a 1 hour marker. So if you're hypoglycemic in a ward, you expect the right treatment to be available, the right treatment given. You expect to have your blood glucose level checked in 15 minutes and have your hypoglycemia resolved at least by 1 hour. And you can see that we're pretty hopeless at doing that. I think we're good at treating hypoglycemia, but we're not good at rechecking blood glucose level to evidence that the person has recovered. So in Ninewells Hospital, our compliance with good hypoglycemia management appears to be the latest 45%. In PRI, it's less, it's 37%. So if we look at the hypoglycemia incidence, this is in Ninewells, the blue line is the number of episodes of hypoglycemia per month, and the red line is the number of hypoglycemic episodes that have been resolved within an hour. So we've got loads of room for improvement. We want to see these two lines come together. And that gives us our percentage there. So what can we tell from the hypoglycemia data? This is really powerful, and this is what the government are going to be looking at through a national dashboard, we hope, in the very near future. If people are hypoglycemic, there's more patient harm. We know that it's a marker of quality of care. We've got issues with insulin safety. We're looking at medicines reconciliation, making sure that people are on the right medicines and the right medicines for their age. We don't want people who are 90 years of age on a big dose of a sulfonylurea. We need to look at nutritional standards. We've got somebody referred to us today who's been in hospital for 3, nearly 4 days, hasn't had anything to eat yet because they're very unwell. When do we bring in the dietitian to these patients to offer them nutrition? We know that hypoglycemia increases morbidity and mortality, it increases length of stay, reduces patient flow, and it will increase bed days, and it increases the workload for staff. It allows us to know whether there's an educational need in the ward, and we did have a big issue with nurses putting the date of birth and CHI into the blood glucose meter, but that's improving all the time. Out of all the blood glucose levels that are done, and we do 10,000 in Ninewells per month, only 60% had a valid date of birth and CHI. When we last looked, it was 75%, and I think it's possibly better now. Dr. Chris Sainsbury from Glasgow has done an economic analysis on hypoglycemia with Niels Michael from Healthcare Improvement Scotland, and these assumptions were based on early pilot of Diabetes Think Check Act. And it tells us if the incidence of hypoglycemia can be reduced by 20%, then we can reduce the length of stay in hospital between 1 and 2.5 days per patient. And if we successfully manage hypoglycemia by 50%, then this leads to a length of stay reduction of 1 day. And if you look at our data, we're only treating 45% of our people with hypoglycemia appropriately, so we can improve care, reduce workload, reduce harm, and get some empty beds, but I know they're never empty. Safe management of insulin. We've introduced a new insulin chart in NHS Tayside, and this has been shared with anybody who wishes it nationally. We've shown that there's been an improvement. There was a 17% error rate, and that's now down to 4%. And we're just repeating that audit at the moment. We just take 40 insulin charts on our way round, us being the diabetes nurses, look at the charts on our way round and look to see that the prescription is legible. The preparation of insulin is written on the T-par. There's no abbreviation for units, and the insulin's been administered at each time prescribed. And that's really important, the insulin being administered, because look at our DKA rate in 2017. We've had 6 episodes of inpatient DKA in our university teaching hospital. And we've had 3 episodes that I know of hyperosmolar condition, and 2 were last weekend. Anybody who's interested in taking diabetes improvement forward as a project, particularly for the young doctors, student doctors, student nurses, there's lots of ideas in the Diabetes Think Check Act toolkit. So in summary, we need to get the basics right in diabetes care. None of this is earth-shattering. If we get good blood glucose monitoring, good insulin safety, good response to hypoglycemia, that will improve everything. There's a challenge of improvement, and we've got very interested to listen to Duncan's talk about our challenge for improving foot care. We know that data drives improvement, but we need to share these data with the ward staff. And we're looking for a platform to share these data. We need to improve hypoglycemia management, and enthusiasm is key. So what we've done is we've started up a Diabetes Diamond group, and we have a founder member, Lynn, sitting here from Ward 3, who put her hand up to say that she would champion diabetes care in Ward 3. And from there we've expanded that. We've now got 21 healthcare professionals across Ninewells and Forfar, and Susan Somerville from the University of Dundee is our honorary Diabetes Diamond. So what they are doing is they're interested and they're enthusiastic healthcare professionals, and what we want to do is network with these enthusiastic people to drive improvement in diabetes care. We're going to meet on a regular basis. Mike's another honorary member of our Diabetes Diamond group, and we know that Mike can help share his experience of trying to improve foot care in Ward 4, our diabetes ward. So if Mike can share his idea with the other 20 nurses across the trust, we're hoping that improvement will grow. And just on the final slide, we've got e-learning modules, which are very engaging little modules suitable for whether you're a student nurse or a consultant, and we'd encourage you to do these. They only take about 15 minutes each. They're colourful and engaging. And I'd like to pass over to Duncan now.
Thanks, Debbie. Next speaker is Mr. Duncan Strang. He is a diabetes specialist podiatrist and National Diabetes Foot Coordinator. He's kindly come all the way from NHS Lanarkshire. He works in Hare Myers Hospital and is going to be talking about CPR of feet. So if anybody is wondering what CPR of feet is, you'll soon know what it is. Thanks, Duncan.
Cheers, Pavan. Thank you very much, and thank you very much for asking me up to sunny Tayside. It was a lovely drive up this morning. Just very quickly, I qualified as a podiatrist in 1980, which a lot of you will raise their eyebrows because you probably weren't even born then. And I have been working in diabetes care for about 30 years now. I still spend 3 days a week in our multidisciplinary clinic in Hare Myers Hospital, treating active diabetes foot ulceration, but I'm in the fortunate enough position to have the role as Diabetes Foot Coordinator for Scotland 2 days a week, and also very fortunate to be working with Professor Lees. We work very closely together. Together we set up the Scottish Diabetes Foot Action Group, which I'm the coordinator for and Graham chairs. So we work together on a lot of these national initiatives together to roll them out across the country in an advisory sort of way. So this new national campaign, CPR for feet, really what is that? It's a very simple system to make sure that on admission to hospital, every patient have their feet checked. If their feet are at risk, we make sure that we protect them. And if they're discovered to have an existing problem, we make sure they're referred appropriately. And this is how CPR came about. Now, this came about in Graham's office here in Ninewells Hospital. When we're sitting down, he said, right, what is it we need to achieve here? And I said, well, I would really like to achieve that every patient with diabetes, when they're admitted to hospital, we make sure they had their feet checked. And then if we discovered that they were at risk, we would protect them. And if they discovered if they had an existing problem, then they were referred and referred appropriately. And we were just sitting with a bit of paper and going, well, we need to check them. And it was Graham and I went, well, that's CPR. And we thought that was something that would maybe catch on. And that is genuinely how this campaign came about. And it was just sitting in Graham's office and saying what we would like to achieve, how we thought we could go about it, and then sitting with a bit of paper. So really, what is it we're trying to avoid? And we'll have all seen this sort of pressure damage. Most of the pressure damage that occurs in hospital within our care is avoidable pressure damage. As we know, the sacrum is the most vulnerable area on somebody's body, and the heel is the second most vulnerable area. And especially in our patients with diabetes, it's neuropathy and reduced vascular status are the two things that are going to drive this pressure damage. So who's at risk? To wind it back slightly, we started this campaign as CPR for diabetic feet. And then we realised that there was a lot more people at risk out there than just people with diabetes. And we realised that the elderly, the frail, the immobile, bedbound, chairbound, malnourished, or as we call the special risks, diabetes, vascular disease, CVA, renal impairment. During surgery, sometimes we forget about these patients because they might be in surgery for a long time, and post-op patients. So we were given the advice that to get a campaign like this rolled out, we shouldn't make it disease-specific. I know we're here today to talk about diabetes, and I will be focusing on that. And that is why we decided to move the campaign from CPR for diabetic feet to just CPR for feet. Although diabetes is mentioned a lot in it, we have just taken it out with the title. So the Scottish Diabetes Foot Action Group, we carried out an audit of 1,048 inpatients with diabetes across the country. Now, what did that tell us? That told us that 2.4% of our patients with diabetes were developing an avoidable new foot lesion or pressure damage while in our care. 57% of the patients said they had not had their feet checked since admission. And 60% of the patients that we found to be at risk had no pressure relieving apparatus in place. Now, there was two ways that we could look at that. We could think, well, that's pretty awful, those statistics, but actually Graham and I looked upon that and saying, yes, that is given us a true reflection of what's out there, but it has given us a massive amount of movement to try and improve this. If we look at the key messages from all the guidelines, they tell us that cost prevention is a lot less than the cost of treatment. Now, that is not just in diabetes care, not just in avoidable pressure damage care, but in a lot of other aspects. And decreasing the incidence of pressure ulcers will release staff and resources, and as Debbie has alluded to, hospital beds as well. Reducing the length of stay in hospital. The length of stay of somebody with a pressure ulcer or pressure damage tends to be about 5 or 6 days longer than somebody without, but that goes up to about 13 days with somebody with a diabetic foot ulcer. They are in hospital for about 13 days longer than somebody without a diabetic foot ulcer. So it's a massive, massive resource issue. We know the cost of pressure ulcers range from about just over £1,000 for a grade 1 to over £24,000 for a grade 4. We know that the length of stay in hospitals between £450 and £650 a day, and if we're concentrating on people with diabetes, and especially if they acquire pressure damage which results in a foot ulcer, and if we're talking about an average 13 days longer, That's not just extra bed days, but the cost of that stay goes up massively involved. And there is this massive increase these days in the chance of litigation. The amount of things out there that patients, or quite often patient relatives, say, well, if they've come to harm, there must be blame, so you have a claim. And the instances of litigation are going up massively for pressure damage. We had an instance in NHS Lanarkshire a few years ago where a patient was admitted with a gangrenous left first toe, developed avoidable damage on their right heel, which they had been given pressure relief to avoid that, but had refused to wear it, developed avoidable pressure damage, which became infected, osteomyelitic, and ended up with a below knee amputation. They sued the trust and they won. Why did they win? Because although they had given the appropriate pressure relief, it wasn't noted in the notes that the patient had refused to wear it, and we all know that if it's not written down, it didn't happen. So they came in to investigate the case, opened up the case notes and said, oh yes, but we told the patient they should, right, where's that written down? It wasn't, they just closed it and wrote the cheque. And that is the culture that we're living in these days. And litigation is a massive issue, and it seems to be a massive issue with feet especially. So why do we need CPR for feet? Hospital-acquired ulceration, it is unnecessary in most cases. It does delay discharge. It is easily preventable, causes unnecessary distress to patients. As I say, results in litigation, and it costs the National Health Service an absolute fortune. When we looked at the data from our audit, we worked it out with the amount of bed days, and I worked this out with somebody from the Scottish Government, and we reckoned that just in the patients with diabetes, if we managed to avoid 75% of the avoidable pressure damage, it would save the health service £15 million a year. Now that's just in Scotland, and we're not a massive place. So, and I don't want to keep banging on about cost. We're not here today to just concentrate on cost. We're here to concentrate on patient care and avoiding avoidable harm to our patients. But we have to bring in that cost as well to highlight to certain people the size of this problem. So what do we need to put in place to ensure that we can roll out CPR? I've developed a Learn Pro module, which is still called CPR for diabetic feet. And that, it's not one of the compulsory modules, but it's on the CPD part of Learn Pro. And I would encourage you all to make sure that in all your wards that people, and I would try and keep an audit of the people who carry out that module. It's a very simple module. And as you can see by the size of my forehead, it was a lot of hair pulling out to build that module. I don't know if you've ever built a Learn Pro module, but it took a while, but we got there. We've got to encourage ward staff to carry out this module. We've got to increase the awareness of all aspects of our diabetes patients, our risk and the risk they are at. Highlight the importance of prevention, because as we all know, prevention is much better than cure, not just for the patients but for our budgets. And we've got to highlight the cost of financial terms and of patient harm if we get it wrong, because please understand, if a patient gains pressure damage within our care, we have got something wrong, and we can't get away from that. What I will encourage is CPR posters and pressure relieving algorithms to be in each ward. I have funds from the Scottish Government to make sure that happens. And we've got to ensure that each ward has one of these CPR posters and a simple pressure relieving algorithm. That's these here. I brought some with me today. Simple poster on the left-hand side, CPR for feet, and it just highlights that we should be checking, that we should be protecting, and then we should be referring us to local protocol. I know there is a major lack of inpatient podiatry input, and that isn't just in NHS Tayside, that is across the board, across the country. and we had discussions. I had discussions with Pavan over lunch today, and I would feel it would be justified in each hospital this size to have a full-time paediatrist coordinating discharge, care within the ward, and post-discharge care and everything. It would make it's an absolute no-brainer. We don't have the resource for that, so we have to think cleverly about how to do things. And I think cleverly the way to do things is to make sure we have somebody assigned on each ward to take control. I was speaking to Mike earlier, and he seems to be completely all over it in Ward 4 here. And there was a lot of people nodding to say that they wish their Mike in every ward in the hospital. And I think that is not true just in Ninewells, but across the country. So these two simple posters, laminated posters, should be visible in each ward to make sure that people are aware of the campaign. I've come up with the idea of CPR badges, which are on a lanyard, which just reminds us about checking, protecting and referring these patients. And in the back of that there is a mirror so that we can check patients' heels. I've only got a couple with me, and Mike will be getting one before we go, as he's seemingly the local star. So, but I've also been given funds by the government to make sure. We reckon there's 1,000 wards across NHS Scotland, and they've been given funds to make sure that there are 2 or 3 of these badges in every ward, and they seem to be going down very well. And it basically saves people breaking their back checking patients' heels and having to contort to look at the heels. A very, very simple thing like a mirror, and it is proving very successful. Include CPR for feet in your admission paperwork. Now, that isn't for a lot of us to decide within this room, but it could certainly be directed by some of the people here. This is what we've done in one of the versions of the paperwork in NHS Lanarkshire, and you can see 8D there, and it is foot assessment, and just very, very simply check, protect, refer, where they checked, where they protected, and where they referred. We are all very, very busy. I had devised paperwork just solely to go along with this campaign, but it was like a heart sink every ward I went to. Said, oh, more paperwork, more this, that, and the other. So I would encourage, if you can, and when you're reviewing your admission paperwork or your assessment paperwork, get your tissue viability people involved and have a look at the paperwork, and just very simply have this in here as a prompt. It doesn't need to be complicated, it's just to focus people's minds. Assign a ward pressure champion. I've already spoken about that. And give a member or members of staff the responsibility for CPR for feet. It doesn't necessarily mean to be nursing staff. A lot of our healthcare assistants are very not only willing to do this, but in my experience, a lot of them take fantastic ownership of this and drive this forward very, very well. And as I say, it can be any clinical support worker, any healthcare assistant. I'm not bothered who takes responsibility for this, as long as they take ownership and drive that forward. Ensure appropriate pressure relief is immediately available. What I've done throughout NHS Lanarkshire is to make sure that there is a stock of first-line pressure relief in every ward. And what I've organised there is to have it an automatic top-up. I presume you've got the same system throughout your wards here, that there are certain items that are an automatic top-up, that they don't need to be ordered, but they are just replaced and replenished each week, items that are used on a regular basis. And somebody comes round our hospital 1 day a week and checks, and the pressure relief, if the standard is 6 items of pressure relief, if 3 have been used, they're topped up by another 3. If none have been used for some reason, then there's none topped up. If they've all been used, they get topped up. But it's just to make sure that we must have appropriate pressure relief, preferably the one that's been approved by the National Distribution Centre, because that keeps our costs down. And anything that's in the National Distribution Centre has been agreed nationally. Quite often, if the podiatrist is called to the ward, the initial pressure relief that has been put on in place in the ward at the time when they've realised that there is damage to the patient might not be suitable for various reasons, and usually it's the podiatry, the orthotics or the tissue viability department that hold an extra stock of maybe slightly higher level pressure relief for that. But it's just about keeping it simple. Simple pressure relief on the wards, simply checking, simply doing this. If we make this complicated, it's not going to work. Basically, what we're trying to do here, and what I'm trying to highlight, is what we basically should be doing anyway, but it's just to highlight the basic things that we should be doing. Ward-based training. Try and get buy-in from your chief nursing officer, your TVNs and ward sisters. Training carried out by podiatry TVNs, preferably working together. That is what I've found the best, just doing buzz sessions. Pavan's talked about his T-trolley approach, which I don't know if everyone in the room knows about that. I think it's a fantastic idea. But short, sharp buzz sessions. And I've found that going hand in hand with the tissue viability nurse, and sometimes having the chief nursing officer on tow as well, makes people stand up in the ward and they can see the level of support this is coming from. Debbie did allude to the letter from Jason Leach, but Shona Robison, the Health Minister, has announced this as part of during a patient safety programme in Parliament. This has now become government policy for Think, Check, Act and CPR for feet. So this isn't something that the Foot Action Group or Debbie or something thinks is a good idea that we should be implementing. This has now become Scottish Government policy. I would encourage the culture of preventing avoidable pressure damage. It is all about prevention. I would encourage the culture of detecting damage if it does occur, but getting away from the blame culture. Quite often when you introduce a campaign like CPR for feet, you may notice your DTEX rising because people are appropriately using the DTEX system. So initially you might see a rise in your DTEX, but I wouldn't let that worry you. That is just something that we would expect. We need to prevent the preventable because, let's face it, a lot of these, the pressure damage is avoidable. And one of the strap lines that we've decided to use with this CPR for feet campaign, bearing in mind that it takes about 30 seconds to check the feet, and you could end up with a patient staying 13 days longer in a bed because of avoidable damage. So it's spend 30 seconds, save 13 days. It might sound like a simple strap line, but that seems to be getting a bit of a message across as well. We've got to try and save bed days. We know that is what this whole campaign's about. It does save massive amount of nursing time and podiatry time. If a patient gets avoidable damage, the dressings and the time to carry out all those dressings is absolutely massive. I have touched on preventing litigation, and it saves, in the long run, it saves a lot of our valuable budget, which we all struggle for. And let's face it, probably the most important thing is to prevent avoidable harm to our patients. That's why we're all in this room. That's why we come to work each day, to make sure that we provide the appropriate treatment. And if patients do, especially the ones that we're here talking about today, get avoidable pressure damage, it isn't just a bit of pressure damage in the heel. It can end up with an amputation, and sometimes even worse than that if somebody becomes septic. So don't just think, oh, well, it will be preventing a wee bit of pressure damage in a heel. It can be a lot greater than that. So, and it is within our hands to be able to try and prevent that, but just simply doing what we should already be doing. Thank you for listening.
Righto, thanks very much. Has anyone got any questions or comments? Get this microphone to work and we're off.
Just extending the CPR analogy a little further, we know that in heart disease that every second counts in terms of a myocardial infarction, and it's just the same with the diabetic foot. Every second does count in terms of tissue loss. The earlier you get onto an ulcer, the quicker it heals, and therefore the less problems that develop later on. And one of my favourite quotes is from 100 years ago, and a Canadian guy who said, "For every one problem we have for not knowing, there'll be 10 for not looking. There's no excuse for not looking, and I think it's horrendous that actually more than half of our patients don't even have their feet looked at.
And what are we looking for, Graham?
Two things, really. One is, Duncan's not mentioned it, but he could do it, is in the programme, the touch the toes test. All you need to do is touch the toes, and if the patients can't feel you touching, then that's a significant sign of neuropathy that they need some protection. And if they have tissue loss or problem with an ulcer, then refer to the diabetes team.
And presumably this Learn Pro module has more detailed information about the kind of things we're looking for. Because, I mean, we in acute medicine, as an acute physician over there, we see a lot of cuts and bumps and scrapes and bruises and funny bits and pieces. Do you want to see the whole lot, or?
There clearly has to be an element of common sense, but it's where the pressure areas are, and if there's neuropathy, then patients need to be protected. And the audit showed that about a third of inpatients will have neuropathy, so it's big numbers.
It's getting the appropriate pressure relief as well. Now, I've broken that down in the algorithm. Now, I've got some posters there, will explain it more, because there are different needs for somebody who's ambulant and non-ambulant. We don't want to create a falls risk for our patients, because they think, oh, well, maybe the loo's just over there, so I'll not bother taking this boot off till I walk there. So it's getting that right, and that's where the education on the ward takes place. I put up a couple of quick photographs of very initial pressure damage, which was type 1 damage, down to an ungradable one because of that. But you're basically looking, especially at the patient's heel, for any areas of redness, any areas of blanching skin, anything like that. And the Learn Pro module does highlight our patients with diabetes won't move their feet when they're becoming vascularly compromised, because they're not getting the signals because of the neuropathy. So we do quickly check for neuropathy, and it's all in the Learn Pro module. I didn't go into it in great deal, but that's to encourage you all to do the Learn Pro module.
Debbie, I bet you know what I'm going to ask you. Have you had any progress in getting the data, hypoglycemic data, available for ward teams? Because it's a bit, as you say, data drives improvement. If we don't know what our performance is in relation to this, we can't improve.
So that's a great question. Thank you very much, because I am looking for help with that. I've been on to the ClickView people because I thought that is a good. It's a performance management system, I believe, that we can display data. But I've been told that the ward nurses probably don't look at that, and I haven't been able to progress it through ClickView. We have a meeting with NSS. It's working. NSS Scotland next week, looking at a national dashboard, but that's the information coming from the connected blood glucose meter data into Track Care, into Sky Diabetes, but we still need that platform to share with the ward staff. So if anybody knows anything about dashboards in NHS Tayside, let me know and I'll go and speak to them. Because we've got great support from Sky Diabetes, and they've set us up. I take some data off myself from the COBA system and feed it back to the ward. So I'll go to Lynn and I'll say, you've done 100 blood glucose levels this week in Ward 3, Lynn. 4 of them haven't got a date of birth and CHI that's valid, and you've had 2 episodes of hypoglycemia, both resolved within an hour. Tell your staff that's fantastic. But that's quite time consuming, because all that data is sitting there ready to be used.
Gordon.
Hi, Gordon McClay, GP in Perthshire. I just wanted to check, you said there's a new insulin chart for NHS Tayside, and I'm hoping and assuming that's rolled out across the whole of NHS Tayside, including community hospitals. And I'm just wanted to check that community hospitals aren't forgotten about as part of this whole programme, because obviously the patients we look after are particularly frail and elderly, and I would imagine at risk of the very thing you're talking about. So I think it's just important. I'm glad to hear that that's still within your remit and your thinking. So thanks for that.
Do you want to comment on that, or I'll give you the microphone because then it gets recorded for people listening at home.
So when we implemented the insulin chart, that was in May this year, we had some help from the pharmacists, including the community pharmacists, so that we made sure that all the outlying hospitals did have an awareness. We did education sessions for staff to attend, and one of our diabetes diamonds comes from White Hills, so we're very happy to have anybody from the community hospital who wants to network with us, whether it's virtually by email or telephone or joining in through a video conference, because we know there's a lot of frail elderly out in community. We haven't been able to roll the insulin chart out to community, but we're encouraging the ward staff to photocopy the prescription to send out to the community hospitals, and that's all not to community hospitals, to care homes and for district nurses. The problem with the insulin chart going into care homes, who's going to pay for them? And the charts cost 10 pence each, they're not very expensive, but the care homes have made their own charts, and they're probably not going to adopt ours, but they're welcome to have it. I know in Dumfries and Galloway they're rolling the insulin chart, which is a copy of ours, out into community, and they're doing it very successfully.
We await our diamond champion from Ochterada.
Right, so let's call things to a close. It's 6 minutes to 2, so we'll stop there. I'd like to thank our speakers, Pavan and Duncan and Debbie, for coming and giving us insight. I like your diabetes chart, so the insulin chart that has the graphs on it. You know, how many years have I spent teaching medical students drawing those graphs inaccurately, and now it's on the prescribing charts, so I actually know what's going on. It's fantastic. I really like that. Small things make a big difference. Anyway, small things make a big difference. Check, protect, refer. Yeah? Excellent. Marvellous. Next week, it's DCAT Discovery Travel Awards. Always really good. The people who've been awarded their travel awards, they present their findings. So see you again next week. Thanks very much. Round of applause for our speakers.